Hi, thank you everyone for joining us.
Hi, good afternoon.
Hi, I'm Dr. Horn.
Dr. V.
And today we're going to go over diagnosis and treatment of cellulitis. So we're glad that you can all make it. Now, everyone, as you join, your microphones are on mute. But if you have any questions, feel free to unmute and ask any questions that you have. Or if you'd like, you can type in your questions and we'll respond to your questions that way. So we'll go ahead and start off. So today we're going to be talking about cellulitis, and we get our recommendations from the Infectious Disease Society of America recommendations. And so that's what we try to stick with, and these are things that everyone kind of agrees with. So we're going to go over a little bit on assessment and diagnosis, on what it looks like to have cellulitis, and then we're going to focus mainly on treatment. And we're focusing mainly on treatment to go over what to do in these clinical situations. So what should the clinician focus on, and what's important, what's not important. So we'll kind of go through it and touch on a lot of subjects.
I feel like cellulitis is one of those bread and butter cases that, we can't talk enough about it because, we see so many cellulitis. So it's a good opportunity for everybody to ask questions and collaborate.
And this is something that's exactly, it's very common, and sometimes just a little bit of information goes a long way. So assessment and diagnosis, because cultures are usually unrevealing, most cellulitis cases are diagnosed by history and physical exam alone. So just by looking at it. So it's a clinical diagnosis. So a patient comes in, and then the next part here is cellulitis is an infection of the deep dermis, erythema, warmth, tenderness, and swelling. So when you look at it and the patient has red skin and it's painful, and usually it's painful to light touch. So just by touching the skin lightly, they'll have a lot of pain. Now diabetic patients that don't have any feeling in their feet, they won't have any pain at all. But if it's warm, tender, it's swollen, these are the things we look for.
And I think it's so important to put on a pair of gloves and actually touch the skin to feel the warmth. Because sometimes, if you have like venous stasis, for example, you'll have red extremities as well as skin. So it's really important to touch the skin, feel if there's pain, if there's warmth or tenderness.
Yes, that's a really good point, because if their leg gets swollen really quickly, then it can look just like cellulitis, and it's hard to tell the difference. So if it's red and it's swollen, if it's warm, if you're trying to tell the difference between edema and cellulitis, if it's warm, you're thinking more along the lines of cellulitis.
And one of the trick to figuring out if it's edema versus cellulitis too, cellulitis tends to happen on one leg for the majority of the time. Edema, when it happens, usually sometimes you have to on both legs. So kind of that might sometimes help as well.
Yes, that's right. And you can get cellulitis in two legs at the same time. And sometimes, if that's going to happen, we're thinking about patients that usually they're immunosuppressed in some way, or they have a lot of lymphedema, they have really swollen legs, diabetes, a lot of these things a lot of issues that put them at high risk anyway. They may get it in both legs, so it does happen. And then elevated labs with cellulitis. So labs are not always helpful, and this is essentially to show you that they may not have a leukocytosis, they may not have ESR or CRP being elevated, but if you look at the leg and you say that looks like cellulitis, treat it like cellulitis.
Yeah, because when you have white count goes up or ESR, CRP, you have to have a systemic reaction, and cellulitis sometimes is so localized, you might not get those labs tested turn abnormal, but they still have the infection.
So risk factors associated with the development of cellulitis. So when we see these patients, they usually ask us, why did I get this? Why am I getting this infection? And usually what I say is that I think more on the lines of high-risk patients. So if you have a patient, and here it has primary, they have systemic and local. So systemic being that older age, obesity, homelessness, and then local issues. And these are local meaning their leg or their hand. And here they have local trauma, they have edema. So when I think of this, it's usually local, so they have a break in the skin, And then things that will hurt the vascular supply, the blood supply to that area, so it makes it hard for their body to go and heal if their blood can't get there to heal up.
Another, for recurrent cellulitis, again, it's the same thing as obesity, if you have prior history of malignancy, but smoking is a big one.
Yes.
So, we try to tell our patients if they're getting recurrent cellulitis infection, it's so important for them to quit smoking, because when they continue to smoke, you have all these inflammation that are happening locally at the skin level, and you're not getting good blood supply, you're not getting good white blood cells to like heal the cellulitis. So we see a lot of patients that get recurrent cellulitis with continue to smoke. So it's really important to counsel the patients on stop smoking.
Yes, exactly. And so I usually tell people that's the best thing you can do right now for your health is to stop smoking. And the cigarettes, they hurt with peripheral arterial disease, so the chronically, but then in the acute and the setting when they're in the hospital, if they continue to smoke, they'll have vascular constriction, and it hurts the blood supply just at that moment as well.
And I try to explain to our patients in a term that they understand. I tell them, white blood cells is what fights infection. So if you continue to smoke, your white blood cells that fight infections, they're not going to work properly. So the infections are going to continue. So I think like when we explain it in a way they understand, sometimes that makes sense. Now the big one for recurrent cellulitis is also tinea pedis. So it's so important to look at a patient's feet to see if they have fungal infections in the toe, in between the feet, and treat that, because when you have fungal toe or feet fungal infection, that causes injury to your skin. We might not be able to see it microscopically. You're going to get skin breakdown. And then the bacteria that's on our skin, then now it can go inside and cause cellulitis. So whenever I'm treating cellulitis in a patient, I end up treating the fungal infection as well, so they don't get these recurrent infections.
Right, and whether it's a fungal infection on the skin, it makes a nidus of infection, a way that the bacteria can get in, or nail infections. It's the onychomycosis. Also, in the past, they used to say it's just a cosmetic issue, and they'd say, they'd kind of joke and say, if you don't care how your feet look or something, and usually the tough guys will say, oh, I don't care how my feet look. But it's actually important to treat that because in the long run, it can make it a way of the bacteria getting in and actually causing osteomyelitis in that area as well.
So it's really important to look at a patient's feet and make sure they don't have fungal infection.
And another one that's on here is a history of malignancy. And sometimes more so in the past when they would go in and do surgery for cancers, they would take out a lot more lymph nodes. Now they try to do more sentinel nodes than taking out 50 or 100 lymph nodes. But that also puts them at higher risk for recurrent, usually strep infections. But those patients can come in many times. Usually it's women with breast surgeries where they've had a lot of lymph nodes taken out, or men with prostate cancer that have had a lot of lymph nodes coming out, that specifically at high risk for those patients as well.
So, we get a lot of question about culturing. So our rule of thumb is that if you have cellulitis, some patients, we're going to get into it a little bit more, there's no skin breakdown, it's just red and hot. In some patients, you'll have skin breakdown and there's abscess or drainage. So only time that we will culture those abscess or drainage is to see if there's Staph aureus, if there's MRSA or MSSA. Because studies show 50% of the time, if you do have MRSA or MSSA, then that's what's causing the infection. So for us, because when you swab a person's like open wound and it's dirty, you could grow so many different organisms, but only helpful one is when you grow Staph aureus.
Right, and usually when I'm asked about taking cultures, I think to myself, it's okay if you know how to interpret it, if you interpret it properly. Because a lot of the time they'll grow coag-negative staph, and they'll grow Staph epi, Staph capitis,
Enterococcus. It just hangs out.
There are things that are normal that if you swabbed my skin you'd find as well, and that's what it's saying here, that it's not involved in the etiology of the underlying cellulitis. And then most coag-negative staph, you'd need vancomycin to treat. So those patients wind up on vancomycin when really that's not the causative organism. It's not really a player in the cellulitis.
The big ones for cellulitis we're going to talk about a little bit more. It's like staph and strep.
Right. And so here we have Staph aureus is the organism most frequently isolated from needle aspirates or punch biopsy samples. Now, but most of these cultures are negative. Now, when a patient comes in with cellulitis, we don't recommend doing needle aspirates or punch biopsies to get the organism. And the reason is because of this, 70% are negative. And then people will say, well, how can it be so red if you're not culturing anything, if you do put a needle in? And the reason is because they think that it has the toxins, and there's so much toxins and so much inflammation that more so than the number of bacteria that are there. But anyway, so to focus on the important part, we don't recommend doing a needle aspiration or punch biopsy. And strep pyogenes and other beta hemolytic strep cause most cases of cellulitis. So the takeaway there is that you don't need to treat MSSA or MRSA every single time you see a patient with cellulitis.
Yeah, and we'll get into more purulent versus non-purulent. But MRSA has become more predominant pathogen for suppurative when there's pus, you have from the skin infection, such as furuncles, carbuncles, skin abscesses. And what's the name of that recurrent infection that you get?
Oh, hidradenitis suppurativa.
So
yep.
Hidradenitis suppurativa, it's a recurrent abscess patients get underneath their armpits, in their groin, and it's really severe. And I'm sure you guys have seen these patients in the past. Just remember, if you do have a patient like this that is getting recurrent skin infection and they have hidradenitis suppurativa, now there's immunomodulator treatments. So it's really important to refer them to a dermatologist because they are able to help us give the immunomodulator treatment. And it's really important to get these patients into a dermatologist earlier in their course of disease than waiting later on. So just keep that in back of your mind.
And those patients, as with essentially all patients, not just cellulitis patients, would be stopping smoking and losing weight and doing the underlying factors that you can help.
Yeah.
But that's a good point, because recognizing these patients that with recurrent abscesses as something that they need to see another specialist for and get treated for. So MRSA cellulitis. So for cellulitis, therapy should be directed primarily at beta hemolytic strep. So you can have cellulitis from MSSA and MRSA, and we'll see as we treat it that the first division is there pus or no pus? And if there's pus, you're thinking more Staph aureus, and if there's no pus, you're thinking more strep. So as far as pus and abscesses, carbuncles, furuncles, you're thinking Staph aureus. So then it's important to cover MRSA and MSSA, but there's been kind of a shift of treatment that a lot of the clinicians are treating MRSA and MSSA when they don't need to. So not every patient you need to cover for MRSA and MSSA. And there was a well-designed trial showing no benefit of adding, this is Bactrim, to cephalexin, that's Keflex, for the treatment of cellulitis. So they took patients that had a cellulitis with no pus, and they compared it. They looked at cephalexin versus cephalexin plus Bactrim, and there was no benefit of adding Bactrim to those patients. So that's a good point, that most of the patients where you're looking and you say this looks like a strep cellulitis, you don't need to add doxy or Bactrim or linezolid or something in addition.
And these type of cellulitis is, again, it'll be red, it'll look hot, but there's no skin breakdown, there's no drainage, there's no pus. So then you could feel confident, this is more strep species.
And then wanted to include a slide just when we're talking about beta hemolytic strep. So this is what we're talking about. So strep pyogenes and strep agalactiae, those are the ones that we're focused on for most cases of cellulitis.
Yeah, and to know about strep pyogenes, so it's group A strep, that's what causes strep throat, it can cause cellulitis, so it can cause lots of different infections. And strep agalactiae, this is usually causes infection in babies and pregnant moms, but it's notorious for causing cellulitis in diabetic patients and cirrhotic patients. So it's a big group of bacteria, strep agalactiae, to cause cellulitis in diabetic and cirrhotic patients.
And these are where we get the recommendations. So if you're interested in looking at where specifically we got our recommendations, or really if you have any questions about it, you can always email us and contact us, and we'll send you the specific articles that we discuss in this webinar. But this is what we want to talk about. This is an important slide. So this doesn't need to be memorized, but if you look at it and then you're aware of it, and you can always refer back to it. So we're going to start up at the top. So on the right, you see there's purulent, so there's pus, and then on the left, there's non-purulent or no pus. So that's the first division. So when you're seeing one of these patients, you say, is there pus or no pus? And if there's pus, you're thinking Staph aureus, whether that's MSSA or MRSA. So if there's pus, they have abscesses, carbuncles, furuncles. Those are essentially larger abscesses. They get larger and larger. So the first kind of all the way on the right here, it says mild. So incision and drainage, IND. So if the patient has an abscess, you can do an incision and drainage and send them home with, and you'll see no antibiotics here. So usually if you look at it and you say they have an abscess, it's not too large and no cellulitis, you can IND it and send them home. Now, if a patient goes to the clinic, they may get IND'd and sent home, but usually if they're in the hospital, we consider it at least moderate. And that's because, depending on how bad it is, if they were bad enough to get hospitalized, we'll probably start with moderate. So it would be okay to IND it and not start antibiotics on some patients.
And they say if the abscess is less than 2 centimeters, sometimes they even give diameter of the abscess too. Just INDing it in the ER and sending them home or in the urgent care is totally fine.
Yeah, and exactly. And part of the reason we know this is because, especially in intravenous drug users, in inner cities, they'll have clinics, and the patients will go in and they'll just cut it open and kind of drain it and not give them any antibiotics, and they do fine. Or patients, they'll have it cut open and they'll say, oh, I never took my antibiotics, and they do well. And with most abscesses in the body, if it's just opened up, that's really the treatment. So moderate. So moderate, it says incision and drainage plus CNS, culture and susceptibility. And then empiric treatment, so this is Bactrim or doxycycline. So you want to give something that covers Staph aureus very well. So both Bactrim and doxycycline both cover Staph aureus very well.
Over 90% susceptibility to Bactrim or doxycycline to Staph aureus, and has great bioavailability. So it gets into your tissue extremely well. So either one of those drugs works really well. And one of the things I always say is with doxy, make sure you put sunblock, especially in the summertime, so they don't get rashes. So it's important to kind of explain things to the patient, but both drugs work really well.
Right, and that's a good point. So you don't need a PICC line for these with these antibiotics. You can just give it to them PO, and they do very well, right? And you'd always want to check your local antibiogram at your hospital, but most places across the country, I think Bactrim and doxycycline, they work very well.
Yeah, in Nebraska, they sent us about a year ago when they looked at susceptibilities to Staph aureus to different agents, and Bactrim and doxy had over 90%. Yep. So all the isolates around Nebraska. So I think and that's really good.
And then once you have defined, so once you've identified it as MRSA, you can give Bactrim, or MSSA, you can give dicloxacillin, or cephalexin, which is Keflex. Yeah.
Sometimes with Keflex, one of the tricks we do is it might say do 500 4 times a day, and I can't remember to take vitamin once a day. So I try to make sure that we're doing the right thing for the patient, so they remember to take their meds. So it's okay to do 1,000 TID instead of 500 QID, so they actually take their meds as well.
And then the next one, following along with purulent. So severe, so IND plus culture and susceptibility. So empiric treatment, so you'll see that IND was no antibiotics. Moderate is, mild is no antibiotics. Moderate, you can give PO antibiotics, and severe IV antibiotics. So you have vancomycin, daptomycin, linezolid. Ceftaroline is a 5th generation cephalosporin that the only cephalosporin that works against MRSA. So you can start with IND, culture and susceptibility, give IV antibiotics, and then once you have a defined, identified and susceptible, you can give, for MRSA, you can give any of the empiric, and then MSSA, you can give something like nafcillin, cefazolin, clindamycin.
Yeah. So this chart is really nice. It's a great cheat sheet. Do you want to show them the picture in the next slide?
Oh, yeah. So, yeah, so here are some pictures of abscesses.
So, you know, it's clearly abscess, it's drainable, some are not, but, you know, the second picture, you could see some probably they already drained that area. And Dr. Horn and I were just talking about, do you need ultrasound in these cases to see if how deep the abscess is? And, you know, we don't think you need ultrasound in all these cases. I think main thing is being able to IND and open that up so it drains.
Right, and this is a common question. They'll say, you know, I'll look at it, like this bottom picture here. I'll look at it and I'll say, that needs to be drained. I recommend draining that. And with our residents, sometimes the residents will say, you know, they won't want to consult surgery or consult somebody to drain it, and they'll say, oh, I'll get an ultrasound. And then they'll get an ultrasound, and it's common to get fluid under the skin and kind of, with cellulitis, you want kind of your body to go in there and the immune system to go and fix it. And so you get fluid just like you would a pneumonia. You get your body is kind of having the appropriate response. So the ultrasound may say something like there's fluid, but they don't see a definite fluid collection to drain. But really, if you can feel it, you can touch it, you can see it. And then sometimes I'll say, the resident will say, oh, the CT didn't see very much. And I'll say, oh, okay, I really think it needs to be drained. And I'll come back the next day, and they'll say, oh, we got a CT. I'll say, oh, a CT, I think we could see it though. It's warm, it's hot, there's fluid under there. And so really, the part of this that I want to say is that trust your clinical suspicion. So if you feel like there's something in there, you know, taking it, you know, a needle or
a small blade,
a small blade and poking
incision and draining it is important. So like asking surgeons to help with that. That's
right, and wound care. Yes, exactly.
And then now we could talk about non-purulent cellulitis. So then you have severe, moderate, and mild. So when you have non-purulent cellulitis, can we show them the picture?
Oh, yeah.
So we're thinking something like this. It's red, there's no abscess, but you know, if you touch the leg, you're gonna feel hot, warmth, pain. So if you have non-purulent cellulitis, then you're thinking about strep species, especially strep pyogenes, strep agalactase. So you could start with, if it's mild, oral therapy, Pen-BK, cephalosporins, Caflex, dicloxacillin, clindamycin. Clindamycin has great strep coverage, so any one of those oral antimicrobials should be okay. Then, but if they're not getting better and they're just getting worse, fevers are not going away, then if you're in the moderate area, then you could do IV antimicrobials like ceftriaxone, cefazolin, clindamycin, IV penicillin. But then you get into the severe non-purulent cellulitis. So make sure if it's severe, they are looking toxic, hypertension, sepsis. They're not looking good with their cellulitis. Think about, it's always really important to think about, we need to rule them out for necrotizing fasciitis. And at that time, you need to give them broad spectrum antimicrobials, Vanco and Piptazo. So you're trying to cover for like strep, staph, Pseudomonas, other gram-negatives, anaerobes. So you're covering them broadly, and then you're trying to rule them out for necrotizing fasciitis. If you're worried about necrotizing fasciitis, it's like there's some if the patient is that sick, you need to start them broad therapy, vancomycin. Consider adding clindamycin if you're worried about strep pyogenes, and then getting stat surgery consult. Surgery should be their stat. If you want to show them.
Oh yeah. Oh, and there's one more thing I want to mention, and that's clindamycin here. So you can see, so on the non-purulent, you're covering strep mainly, and then purulent you're covering staph, and you'll see clindamycin is on the left covering with good strep coverage, but the only place you see clindamycin on the right is for MSSA once you know that it's susceptible. So clindamycin coverage for MRSA is not very good. So it's about 50% or 60% or so. So if you're giving clindamycin thinking that you're covering for MRSA, that's kind of worrisome because it doesn't cover it very well, but it does cover strep well. So you can see that's why it's over here for empiric treatment without knowing the type of strep or what's causing it. But over here, it's only for MSSA, only if you have the susceptibility report back.
Yeah, and the nice thing about clindamycin is that, you know, we all know for necrotizing fasciitis, you should add clindamycin. And the purpose behind it is it's able to bind to the toxins that are released by strep species. So it's not really as antimicrobials as much as binding the toxins that's being released.
Right, and that's down here, plus clinda, plus clinda. So there are some studies showing that if they have clinda on board, they actually, mortality is a bit better. So you want to start clindamycin in addition to vancomycin and piperacillin and tazobactam. Oh, let's see. And then here, here's some additional strep pictures. So you see the redness.
Redness, no skin breakdown, no drainage, just redness.
And with these patients, if it's red, if you can't really tell if it's due to a cellulitis or not, I usually elevate the leg really high above the level of the heart and then wait about 15 minutes. If all the redness goes away, that's my sign that we can stop antibiotics and sign off. So if it doesn't go away, then consider treating and consider, you know, but if it goes away, then you'll say that's probably from the edema. And then, here are the pictures of the neck fascia pictures.
Yeah, so necrotizing fasciitis, it's really important to remember that patient, like for example, the picture right here, you have a small lesion here, but the patient is going to have pain out of proportion. They're going to have pain that is like 10 out of 10. They're looking very toxic. So it's really important immediately to get surgery and imaging. So if you look at the picture right here, this is air inside the tissue, and that air should never be inside the tissue. So that's what you see when you see necrotizing fasciitis. These bad organisms are releasing all these air because they're reproducing. So, and you know, these pictures kind of look obvious because they look like, okay, it doesn't look that great, there's bullae, but in this picture it's just an open skin wound, but they still have necrotizing fasciitis. So it's extremely important to holistically look at the whole picture of the patient.
Oh yes, and if you put your hand on this patient around here, you might be able to feel the air under there. It'll be crackling, and if you listen with your stethoscope, you might be able to hear some crackles and everything. But the important thing here is that it's not always definitive, and in fact, most of the time, it's kind of not very clear. And so sometimes people say, "Oh, I don't want to bother the surgeon," and they think the surgeon will show up and say, "Oh no, you know, this is definitely not." But from my experience, the surgeons, they're never very sure either, because since it can look so different patient to patient, that sometimes the surgeons have been burned before. And so if they say, do you want to wait a day or do you want me to take them to the OR? I always say take them to the OR, because they'll be able to identify it. And surgery, more than the antibiotics, is really the treatment. Yeah. Now, as far as starting treatment, and I just want to mention also when it comes to non-purulent. So if you look at it now, for us, for test questions, they'll say they don't want to have buzzwords of pus or no pus, and usually strep is rapidly spreading and Staph aureus is slower with abscesses. So on test questions, they'll say things like, the patient, in order to say there's no pus, they'll show a picture of it, and they'll show you the picture of the arm, and they'll say, he just noticed this 20 minutes ago, and it's going up the whole arm, and you'll be able to say, oh, it must be rapidly spreading because he just noticed it and there's no pus. So that's kind of just from a test question perspective. Now, for starting treatment, symptoms typically dissipate within the first few days, but it may take longer, and this is the bolded part is the important part, that cellulitis may appear to worsen in the first 24 to 48 hours despite antibiotics.
Yeah, so it's really important to have patience when patients have cellulitis. and wait to see how the patient is clinically doing. Because, so for example, picture here, it's really, you know, our practice is when there's cellulitis to draw around the redness and see if the redness is spreading. But sometimes the redness, once you start the antimicrobials, can spread. You have them on the right therapy, but it still gets worse. And that's one of the reasons is when you're releasing toxins. I'll let you kind of.
Right. So these toxins, you have exotoxins, and this is when the cell is producing them and kind of putting them out, or endotoxins. And endotoxins, you think more of what's inside the cell, and when the cell breaks apart. So when you first give the antibiotics and the cell breaks apart, you have all this inflammatory stuff and the pieces of the cells that are breaking apart and lysis of the cells. One of our colleagues calls it bug guts, right? So he says all these bug guts come out, all these inflammatory things, and they all spread, causing more redness, more inflammation, and for it to start looking worse.
Yeah.
And so this is a patient that I saw that has this, it's demarcated, so they took a marker and drew around where it looks. And this was a young 20-something man that said all of a sudden this started happening. And so he does have blisters. Now blisters, sometimes people associate neck fash with blisters, but really if you put tension on the skin, so if the skin gets tight from the edema and it kind of stretches the skin, you can get blisters. So sometimes patients will have, they'll have a dressing on that has tape, and the tape is pulling the skin, causing them to get blisters there. So with this one, I think he was probably bacteremic, and then he probably had a strep bacteremia that went out, and it started some of these infections in the skin here. So there's no pus here, so I think it's strep. We started treatment, and then you can see this is day 2. It was spreading past the lines.
And it's really nice. You could see the redness is way outside the boundaries, but clinically the patient was doing okay.
Yes, he was saying his pain was improving. He was saying he was feeling a little bit better, but the clinician seeing the patient with us thought that it was getting worse. So they said, look, it's spreading outside the lines. And sometimes when we get consulted, the ER has done one antibiotic, then the team does another, and then here it starts spreading outside, and then they change to a third antibiotic because they say it's not working. But and then they consult us and we look at it and say, no, that's okay. It can look worse at the beginning. And then, so this was day 2, it's spreading outside the lines. And then here's day 3. So you can see the redness, it's definitively looking better. It looks much better here. The redness is kind of going away.
Yeah.
So it just took a little bit of time.
It's really important with cellulitis to give time to heal. And one of the common questions we always get asked is, how long do I need to treat? And, you know, usually for cellulitis, 7 to 10 days are okay, but every patient is different. So that's why it's so important when you have a severe, moderate to severe cellulitis to follow the patient. And at day 10, if they still need some longer course, you just extend the therapy. So what we always do is make sure they have follow-up, and then at follow-up, if it's looking better, it's resolved, you could stop therapy, but if it's not, you extend the course for another week or so and make sure it clears up.
Yeah, so in a normal healthy patient, it might take 5 days, 7 days, 10 days, but in someone that especially the patients that are high risk for cellulitis, when you're thinking of these morbidly obese patients, they have peripheral vascular disease, they're smokers, you know, they drink a lot of alcohol, they have a lot of these risk factors, it's not going to take 5 days.
Yeah.
Right? So it can take a little bit longer, and usually it's just having patience for it to get better. And then want to just include some other pictures here of, and I would call this a severe cellulitis, not so much of, well, it's more so it's on the hand, which I would say is, I immediately treat it more aggressively. And then it's also, it's got this streaking here. So it's going up the lymphatics and streaking.
And another thing to remember is if you have on your hand abscess or severe infection, it's really important to think about, is there a deeper infection inside and within? Because we have so many small tendons, little bones in here. If you don't treat hand infections appropriately, you could actually get fusing of the bones. You could lose function in your hand. So it's really important to think of it as a severe infection and investigate and treat appropriately.
And then Oh, and the other thing is that we didn't touch on bites, on dog bites, cat bites, human bites,
Yes.
All the bites that people get, but that could be a subject for another webinar. That's kind of a long one.
But just to remember, for dog, cat, human bites, it's always augmentin or is the right drug of choice.
Or ampicillin sulbactam, or piperacillin tazobactam. So one of those combinations. Yeah.
And if they don't get better, it's not that the drugs are not working. We might be missing a deep abscess. So it's important to image and make sure that we're not missing that.
And those regimens are better than clindamycin. So sometimes people will associate and they'll say clindamycin anaerobes, but piperacillin tazobactam, ampicillin sulbactam, and
augmentin. Yeah, and
they all get anaerobes very well.
Yeah, and if you're using Clinda, then you got to use it with combination with Levo, because when you get bite infections, the big bugs you worry about is Pasteurella, Capnocytophaga. So these weird bugs that are in mouths of these animals, and it's so that's why we always emphasize augmentin as outpatient, inpatient unisonozosin. Oh, if they're allergic to penicillin, then you do a combo therapy with being like Doxy and Levo, or Levo and Clinda.
And to have a very low threshold to consult hand surgery, because hand surgery sees these more frequently, and so they're on board and they're aware of it and everything. And then wanted to also touch on Dallafansin. So Dallafansin is something that we get a lot of questions over. It's a long-acting IV antibiotic approved for skin and soft tissue infections. So the half-life is very long, so it stays in the system for a very long time. So this is something that it's approved to try and prevent a patient from becoming inpatient. So if you see a patient in the ER or you see a patient in the clinic and you look at their skin infection, it may be a patient that it may be an IV drug user that you don't really trust to put a PICC line in them, or it might be a patient that you don't trust them to see them again in the clinic because you think they might never come back to the clinic for whatever reason. So
it works really well. The only it's very expensive, and insurance covered in an outpatient setting. So, you know, this is a great drug to give if you're worried about, if you want to give somebody treatment for 2 weeks or so in the outpatient setting. So like outpatient infusion in your ER, urgent care, outpatient clinic, because then you'll get reimbursed. You just can't give it in the inpatient setting.
Right, and this is trying to be studied for that kind of those patient populations, like IV drug users, that you're not sure if they're going to come back, or if you gave them pills, you're not sure if they're going to take their pills.
Homeless patients.
Homeless patients, and then you'll say, you know, if I can't put a PICC in them and I don't think I'll ever see them again, and then if I give them linezolid, are they going to take it? So they're also studying this for endocarditis and for osteo, but those studies haven't been completed yet, so we don't recommend it for those situations, right? And then we don't want to go through this too much. We just want to include it here so you have a reference, kind of acceptable uses for it and unacceptable uses, things that we kind of look at and how we kind of see it.
Yeah, and broadly. It basically, you have gram-positive coverage and not gram-negative. And I think this this type of drug has an area where we should be taking advantage of. You know, it's an expensive drug. I think it's about $4,000 to $5,000, but most of the insurance are reimbursing. So in an outpatient setting, for patients that we cannot do IV therapy, that they need IV, this is a great alternative. Or like you said, for our homeless patients, IV drug users, this might be a great alternative that we could use.
Yeah, it's very similar to vancomycin. So vancomycin is a glycopeptide. This is a lipoglycopeptide. So they essentially just put some fat attachments to it. So it stays in the body for a long time. So people are worried about if a patient has a reaction to it, it's going to be in their body for weeks. But really, it can be dialyzed off if that happens. But those fears haven't really played out. People tolerate it extremely well. And then we wanted to just touch on recurrent skin abscesses.
So, you know, when you get recurrent, see a lot of patients in our clinic that get staph infections over and over again, skin abscesses, and they ask us, what can we do to prevent getting these infections? So we do something called decolonization. So we know staph bacteria hides in your nose, also in your body, underneath
on
your
your arms, your
groin,
groin.
exactly. So what we do is give them mupirocin to put in their nose twice a day, and then also chlorhexidine baths daily. But when you do this, though, it's very important that you every day you have clean sheets, clean towels. In the bathroom, you're not using loofahs or sponges because then that can get colonized with staph. So you're putting the soap with your hands. And if you do that, there have been some success in reducing the bacterial burden on your skin, the load. You cannot completely get rid of it, but you could reduce the burden in your skin, so you might not get recurrent infection. So these are some of the strategies we employ.
Yeah, so if somebody comes back and they say, I keep getting these infections over and over, this is an option for them. It's not great, but nothing is 100%. Also, the thing is that you would never retest them without them having any kind of issue. So the patients want to, they want to come back in and they say, can't you test me to tell me it's all gone? Well, we don't really do any tests for that, but if they have it reoccur, then we know it's not gone. So it makes them kind of uncomfortable because they want to be told it's now gone, you're successfully completed the course.
And I always try to tell everybody, we all have staph in our skin. We all have strep in our skin. And just putting the patient's anxiety down to say that it just, when we say MRSA, just the normal bug that we have, 6-7 people out of the 10 if we swab, it's just more resistant now. But, we could treat it. There's plenty of good drugs. I think there's a lot of anxiety when they hear also they have staph infection. So I think kind of bringing that down is really important.
Yeah, and it's very common. About a third of the people always have it. A third of the people it comes and goes, and a third of the people don't have it at all. And this regimen is more successful if the other people in the house do it as well. So it's difficult if their husband or wife has it on their skin also normally, and then if one person gets rid of it, well, they're just going to get it again from their husband or wife. So it becomes difficult.
That's really good point. And also pets.
Yeah, pets can carry it too.
Pets carry,
dog,
pets carry staph. So like if you are having a dog or a cat sleep in your bed, and if you're having these issues, then they're colonized. They're going to give it back to you. So, those are small things that you could do to kind of try to reduce your risk.
And that's everything we have. If you have any questions, please feel free to unmute yourself and ask any questions. So, and cellulitis, this is something that, we see it every day. And sometimes it's difficult to say if it's cellulitis or not, if someone has redness on the skin. So oftentimes, if they have an underlying issue like edema and their legs frequently are edematous, or they have heart failure, it's trying to get everything under control while giving antibiotics. But it can be kind of tough. Now, one question I've had in the past was about following ESR or CRP daily or every other day or every once a week. So that's not something I recommend. I would recommend just going clinically off of how it looks. And does the patient feel like they're getting better or not? And sometimes patients are on antibiotics for weeks and weeks. And so I would say, if they've been on antibiotics for 2 weeks and it's not getting better, then consider stopping and monitoring off of antibiotics.
So we have a question. How long do they need to do the decolonization regimen? There's different regimens. So one of the things I do is like 7 to 10 day course. You stop for a week and then you do it again for another 7 to 10 days. And then you stop. But in certain patients that have severe infection, staph infection over and over again, they just use chlorhexidine as their soap for their body, like daily. So, but usually the decolonization is about 7 to 10 days and then stop. A week later, you do it again.
Yes, I usually order the largest amount I can from the Walgreens, and they take it, they put it onto a washcloth, and they can wash with it. The other regimen, so there's chlorhexidine, and then there's also bleach baths where they fill up the tub and they may put about a cup or so of bleach in, and that helps kind of get it in all the crevices and get it, kind of everywhere. So we don't want people to be too aggressive with, scrubbing with bleach or scrubbing really hard or something like that. But it's something that, these are regimens that they do help with it. we have had patients say that it helped a lot, but sometimes it's a tough situation. If they have active abscesses, it's better to do it when you know, if you can, once those have cleared up, but sometimes they don't clear up very well. It says, with an otherwise mild skin infection, how much concern do you place with streaking up the extremity? So when I see that, I automatically treat it as severe. And because we'll have patients with it on the foot, and they have it streaking up to their groin, and the lymph nodes in their groin are painful. So that worries me, because I usually consider that strep. And if it's streaking like that, it's quickly spreading. And so I usually put that, I think, severe automatically, and I treat very aggressively. Is that what you do?
I do too, and then I also worry about them having bacteremia too when it starts streaking like that, because now you're spreading into the lymph nodes. And
right, I think, and that shows how quickly it spreads, because some patients within an hour or so, they'll say, you know, I didn't notice this, and then all of a sudden it's streaking up to the groin, and they have painful lymph nodes, and you really want to get that under control as quickly as possible, because those with severe infections and some patients that are at high risk, they'll say, this is exactly like how I was last time I came in 6 months ago with this, and they can go to the ICU, they can be they may have a long ICU stay and get intubated, and it can be really, really bad. So treating it aggressively, quickly with antibiotics, it gives them the best chance of having a good outcome.
And then, you know, strep pyogenes infection. So, you know, everybody thinks strep pyogenes, strep throat, it's not that bad. But for me, whenever I see a patient with group A strep pyogenes, it's one of the scariest things when they have it in the blood or in the skin, because it releases so much toxin, and your outcome mortality goes up when you have strep pyogenes, necrotizing fasciitis, or sepsis. Your mortality can be up to like 50%. So I am very aggressive when it comes to thinking about, is it strep pyogenes, you know, treating and adding clindamycin.
Yes, I completely agree. If someone's going to die quickly, it's more likely a strep than a staph. Staph sticks around, and it'll go to the joints and the bones, and can cause a lot of problems, and it's harder to get rid of. But as far as getting sick quickly, dying quickly, strep is more of a concern, and you really want to be as aggressive as you can with it. All right.
Other questions?
Well, if anyone has any questions, you could always email us. Thank you very much for joining us for our webinar. Next webinar we're going to have is going to be West Nile, and so we'll go over West Nile as we're getting into the kind of the West Nile season. But thank you very much for joining us.
Yeah, have a great day. Thank you.